Hello, everybody. Welcome. Thanks for joining us today. My name is Mike Gibb. I run accountsrecovery.net, and I want to welcome you to today's webinar on opportunities to improve the patient debt collection experience found in Regulation F. The components of the debt collection rule, officially known as Regulation F from the Consumer Financial Protection Bureau, offer a number of industries the opportunity to revamp the experiences that they have with their customers. Perhaps most notably, how companies communicate with their customers is facing a significant overhaul. Today in this webinar, which is being sponsored by TCN, we have a panel of leading experts who are here to discuss how regulation will impact the provider-patient relationship for the healthcare industry and for the companies that collect on healthcare debt. Before introducing the panel, I want to take a quick second and talk about accountsrecovery.net. Specifically, I want to mention an event that started last week and will continue this Thursday called Q and ARM. This Thursday, we have 3 companies who are going to go before a panel of industry experts to answer questions about their products and services. Think of it as Shark Tank meets the ARM industry. While there are no prizes or investments, the information that comes from this discussion should provide great insights into the tools and resources that are shaping the ARM industry for the next generation. I'm going to put a link in the chat box in a minute that you can use to sign up for the event. We have 10 companies that have signed up and 9 panelists who are going to be participating this last Thursday, this Thursday, and next Thursday. This Thursday, we have presentations from Simplicity Collection Software, TCN, and Balto, and they'll be asked questions by 3 panelists, including Jed Peak, Kelly Parsons O'Brien, and Chris Taylor. Now, let me tell you a little bit about today's speakers. Leslie Bender has spent more than 30 years handling compliance, regulatory, transactional, and legal matters for hospitals and financial services companies. Recognized as a national expert on HIPAA and other information privacy and security laws, she was one of the first privacy officers internationally accredited as a certified information privacy professional. She's currently a senior counsel in Clark Hill's Banking and Financial Services Group, specializing in corporate compliance, privacy, transactional, credit, and collections matters. Leslie's a past president of ACA International, serving as president in 2013-2014, and as an officer on its board of directors from 2011 to 2015. A 40-year veteran of the ARM industry, George Buck is widely recognized as a source of thought leadership and actionable best practices for the healthcare revenue cycle market. Most recently, he served on the steering committee of the Consumer Relations Consortium, a Washington, D.C.-based group of 30 large market participants in the debt collection industry who proactively engage with regulators and consumer advocacy groups to bridge the gap of understanding and expectations often present between consumers and collectors. Over the years, he has consulted with the Consumer Financial Protection Bureau, the Federal Trade Commission, and other regulatory groups needing healthcare-specific industry feedback and analysis on proposed legislation. Andrew Gwynn is currently serving as the Senior Director of Revenue Cycle for Ascension, the nation's largest nonprofit healthcare company. He has regional revenue cycle responsibility for Tennessee, Wisconsin, Baltimore, and the District of Columbia markets. Andrew previously served as the Vice President of Revenue Cycle for St. Thomas Health in Nashville, where he served in increasingly demanding revenue cycle roles within St. Thomas Health for 13 years, with more than 20 years in revenue cycle experience. Andrew has been a thought leader in co-developing standard revenue cycle methods and technology drivers for Ascension and R1 RCM. The format for today's webinar is going to be a panel discussion. We encourage everybody to submit questions, and we'll get to them as we proceed through our conversation today. To submit a question, please enter it into either the Q&A module or the chat box on your Zoom webinar control panel. This event is being recorded, and a recording will be made available on accountsrecovery.net. Finally, since we're going to be talking a little bit about compliance today, let me just read the following disclaimer. This presentation is not intended to be legal advice and may not be used as legal advice. Legal advice must be tailored to the specific circumstances of each case. Every effort has been made to ensure this information is up to date. It is not intended to be a full and exhaustive explanation of the law in any area. It should never be used to replace the advice of your own legal counsel. Now, with that, I'm going to get out of the way. I'm going to hand this over to Leslie to carry us through our conversation today. So Leslie, take it away.
Well, thank you. And thank you, Mike, for hosting us today. And Andrew, special thanks to you for taking time out of your day. You are a resource to the industry on all things patient accounting and revenue cycle. And so we're really fortunate to have you today. Thank you.
Thank you.
One of the things that we've observed in the past year, among other things, is that the urgency of the pandemic has caused a lot of healthcare providers to make a lot of changes. For example, really beefing up their digital front doors. We've also seen Regulation F, which is the first regulation ever to interpret the debt collection statute that has been around since 1977, and it is embracing new forms of technology. By way of background for some of our audience, Andrew, can you share with us, if you look backwards over the past 12 months, uh, what are some of the most profound changes that you have seen that affect healthcare, particularly on the accounts receivable or patient, um, experience fronts?
Sure. Thanks, Leslie. If you think of the last 12 months, it's hard to believe here we are 12 months later after the start of this pandemic public health emergency, and we're still in it. The first thing that comes to mind is the roller coaster ride that we've all been on of not knowing what to expect and not having had this type of experience before. When the first shutdown, if you will, occurred back in the early spring that we're fast approaching here, the 1 year mark. I don't think any of us anticipated the changes that we would experience. We went from, in many cases, hospitals slowing down operations for elective type procedures. So we saw significant volume impacts to that increasing over the summer as the COVID case spread slowed down. To then the increasing surge that we saw in the fall and through just recently. Volumes, predicting volumes has been a great challenge operationally. For most acute operators, the ER is the front door of our organizations. And it's been interesting to see how ER volumes have not recovered from the beginning of the pandemic. If you look nationally, I believe there's some statistics that will show about 30% of acute hospital organizations have seen a 30% decrease in ED volumes. That volume just has not recovered from the pandemic, even though most organizations have put in great safety measures to ensure patients are safe when they come in to receive care. You've also seen a real change in how healthcare is being delivered, especially in the lower acuity space, especially around telehealth. Telehealth has really launched from the pandemic into the forefront. Telehealth had been there prior to the pandemic, but I think you've seen material increases, especially in the primary care setting, office visit type setting, less so obviously in an acute hospital setting. But in the ambulatory setting, it's been a game changer to be able to make sure continuity care without the risk associated with social distancing needs, et cetera. So the other thing is in the acute setting, I'd say the technology enhancements around the check-in experience. When we think of how patients arrive from a revenue cycle standpoint, whether it's the pre-registration process, the check-in, either through the emergency room or even for scheduled elective procedures on day of, the industry, there's really been a huge transformation in that check-in process from what's been a historically interview style conversation at a desk, gathering information with a registrar, inputting those data elements, to really a full mobile type experience. And so there's been a true acceleration in how we provide mobile communication for patients, both pre-service as well as at time of service, to check in, whether through email or their mobile devices, trying to reduce any contact from a spread of COVID. And I think that's been a big game changer. So I'd say the pandemic has really accelerated a lot of technology and how we communicate with our patients.
And not to put you on the spot, but has it highlighted any sort of vulnerabilities? I mean, were healthcare organizations digitally ready to, provide value-based care, where they had all these resources like this digital front door? What do we mean by digital front door? What are people talking about when they talk about the digital front door to a doctor's office or the digital front door to a hospital? Do you know what? Can you explain to our audience, like what would that entail?
Yeah, my perspective, being an operator, it's really about just different modes of communication. Instead of the more traditional, telephone calls to make appointments or appointment reminders, a lot of acute hospital operations have been telephone based or paper based manual check-in processes. So that digital front door is really providing access in a way that most industries outside of healthcare have already been at that level. And healthcare, in my perspective, is behind that digital front door compared to a lot of other industries. And so the technology being in play, I think there's organizations, companies out there that have solutions, but it hasn't been at the forefront because there hasn't been the demand to interact, at that level. And I think the pandemic brought on that demand that now, hospital organizations, ambulatory organizations are working quickly to implement, that digital front door to have, a digital experience for our patients, whether that's with scheduling or the check-in, the communication process. And I think a lot of it was driven, again, off the pandemic, the fear, I think, of interacting, especially in the healthcare environment. If it's one thing you can say, if there's anything you can say that came positive out of the COVID experience, I think that's one of the accelerators. It has accelerated the industry to provide that better digital experience for the consumers.
So, George, let's flip over to you for a minute. You've spent a decade or two in the business, both first-party and third-party healthcare collections, and you have evolved yourself over time to understand all these different things. What is it in your mind that people who are in the first-party or third-party outsourcer billing company space should be pivoting to be prepared to do to complement this meteoric and cataclysmic change in the front end processes of healthcare providers? What are some of the opportunities that you see?
One of those $1 million questions, Leslie. Thanks for throwing it at me.
I just saved the easy one for you.
Yeah. I think the arm industry is ready to embrace technology. I think it's there. I think there's vendors out there today that can provide us with the methods, the technology, the processes, the connectivity to do the things that put us in touch with the consumer. Consumers don't answer their phones anymore. I don't answer mine. You don't answer yours, Andrew. Mike, you are the same way. If you don't recognize the number, you
Right.
don't answer it. So we've got to shift to meet the consumer where they want to be communicated with. I'm on the tail end of the baby boomer generation, and I term myself the least sophisticated, most technically challenged baby boomer when it comes to technology. But through being a patient of Ascension Medical Group, I've learned to use their portal. It's great. I enjoy it. It's easier for me, but I'm not everybody else. And I know there's challenges when it comes to today's consumer wanting to use technology. We reach out to people via email, text, whatever the case might be. And everywhere you read, there's spammers, there's hackers. So there's got to be some security, starting with the provider, to let that consumer know that they may be contacted by an outsourced partner. I know at some point in time in this conversation, we may talk a little bit about a handoff letter, but maybe that's where it starts. But there's got to be some harmony between the ARM partners and the provider in terms of, one, do they collect information? Two, can we rely on the accuracy of that information? And three, do they have all the consents? And I don't have the confidence, as well as I know my healthcare partners, I don't have the confidence that I can 100% rely on the provider to provide me that information with those three qualifications I had in mind. So there still has to be some dialogue and some education on the part of both parties, ARM partners as well as providers, in terms of how we can arrive at that harmony. How can we get to that point where we're both secure in the collection of the information, the accuracy of the information, and that all the consents are there. So I think that's the dilemma we face going forward.
let's take that apart a little bit. So, okay, patient realizes they need to avail themselves of, or herself or himself, of some sort of healthcare services. So the patient approaches, in the olden days, 13 months ago, the patient might have got in the car if the patient didn't have a primary care physician, right? And drive to the emergency department and be triaged there, and might sit there for half a day, depending on the severity of the results of the triage, right, Andrew? I mean,
Yeah, it depends on, what's going on. It's not just that patient's care, but obviously what's going on in the emergency department.
so you have the patient. 30% of patients who used to do that don't want to do that anymore, either because they're afraid of getting COVID while they're there, or they've figured out telehealth is a better option and a better use of their time and resources, right? So, so when the patient registers for the original care and treatment, is there a reason, Andrew, that we couldn't capture the patient's communication preferences right then and there?
No, I don't think there's a reason. I think it's an operational challenge, to implement. But conceptually, it makes perfect sense. It's just like most things. How do you operationalize it? Because the complexity of AT systems, how information is shared with your third-party, agencies that do work on your behalf. When we started implementing more of this digital front door, Leslie, as you described it earlier. Early on, the focus was strictly on the clinical access, right? How do we make it easy for patients to still access care and a perceived safe environment around, how they check in or schedule, receive those services. And so a lot of the focus around any type of consent work has been around, that aspect of the front door and being able to digitally communicate with the consumer or the patient. So I think the next step is George describing. How do we take it to the next level and consider the further downstream impacts on the collection process? I think a lot of organizations, initially their focus was strictly on getting access to healthcare, as it should be, right? Priorities first. Let's get them in the door and make sure we're able to deliver quality care timely. And so now I think we're going to have to go back and look at that process of consenting patients and talk about how does that expand beyond just getting into the door, that digital front door experience, all the way through the entire revenue cycle process through the collection cycle. And I think that's where we have to partner with our armed partners from the in the industry to how we build that.
So what you're saying is you're not going to build a digital front door, 3-story house with a swimming pool and landscaping that will put third-party vendors out of business.
No, I don't think so at all. I think I don't foresee that at all. I think it continues to be a partnership. I think healthcare providers will continue to partner and want to do business with agencies to help us with our aged receivables. And I think we want to have a seamless patient experience as we do that. No one appreciates, obviously, going to a third-party agency to be collected or to receive collection notices, but how we communicate with the patient, how we have what I would call a seamless experience is, I think, the key. And so, for instance, if we're communicating with patients electronically on the front end to schedule or to receive medical results or telehealth, we don't want to then move to a collection agency and then go back to paper and telephone if the patient's preference is electronic communication. So it's how do we bridge so we can have that full seamless experience? Because at the end of the day, it's still, the debt's still owned by the provider, the organization, and that's where the patient sees the experience in the eyes of who they receive that care from.
So let's go over to George for a minute here. Go ahead, George.
Leslie, if I can just add on to something Andrew said, I still circle back. We as armed vendors, we have to take it upon ourselves to educate our clients. We can't rely on them to know what our challenges are. Andrew and his team were always good, and Andrew, I reflect back to when we had the TCPA issue with consent to dial. We actually went into Andrew's office, made a presentation on the TCPA, and his ministry was one of the first ministries. And when I talk about ministries, there's several ministries within Ascension, but his ministry was the first ministry to go to their attorneys, put the consent to dial into their registration material, and to give us the opportunity to use to use dialing to our cell phones to reach consumers. Same with another healthcare system that we did. This healthcare system, we went in and made a presentation. They immediately got with their marketing, their attorneys, changed their registration forms, added the consent, and we chose a point in time where we knew the new consent and registration forms would be effective, and we started using dialing. So there's a responsibility on us in the arm industry to educate our healthcare partners in terms of what Reg F is requiring of us.
Yeah, and George, I really appreciate that, and it's those types of partnerships that I think makes you know, regulations like this you know, doable, if you will, for lack of a better word, and achievable by partnering together. Because our success is driven by each other. You know, if we're successful, you'll be successful, and vice versa. And so, you know, having the opportunity to you know, partner together for education, strategy on what the best approach is, I think is critical.
So it would seem then that not only will the healthcare provider be evolving a digital front door, but the smart vendor is also going to be evolving a perhaps harmonious digital front door. So for example, at point of service, the patient could provide communication preferences, the patient could provide consents, the patient could not only consent, but also verify that the patient is providing a phone number and an email address that are actually theirs, that they have authority to give to you for communication purposes, and maybe even provide numbers of other people if an emergency comes up. And all that could be passed along because, of course, Regulation F would allow for that passage of time. Let's go back to the handshake letter George was talking about. George, for the benefit of folks in the audience that aren't familiar with that, in healthcare for a long time, we've had handshake letters, or for a long time, we have had consents that are obtained upfront that get passed through to either billing companies, outsourcers, outsourced business process companies, you know, whatever we call ourselves, you know, outsourced consumer experience centers, whatever they are. So what would the handshake letter do, George?
I related to the days in the commercial market. We called it free demand, the old free demand days, and the handshake letter is much the same. All providers send out some type of final notice, final letter, final statement, and most of them have some language that says this is your final notice. If you don't pay this account by X number of days, we could place you with a collection agency or a collection attorney, take further action, whatever the case might be. The opportunity today, along with Reg F, is for that final letter, final notice, final statement to go a little bit further and say your account may or will be placed with XYZ collection agency. They will be contacting you if we don't hear from you. This is their phone number. This is their website. This is their email address. Giving that patient notification, not only that they may be placed out, but who they're going to be placed with, which can do a couple of things for the provider. It actually may, that final notice may actually have a little more impact than just saying we're going to place you with an agency. It's identifying who that agency is or who that outsourced partner is. And I may say, well, gee, I've dealt with those folks before. I'd rather stay with the healthcare partner and pay them. But at the same time, when it does come time for that initial contact to come from the agency, they already recognize the name. And hopefully they'll recognize the number or recognize the email address that communication is coming from, to cut down on some of that issue we face today in right party contact or no contact. Phones just, nobody answers today. And right party contacts have gone through the floor in terms of us being able to reach people by phone. So this is just one more opportunity for providers and agencies to enhance that consumer experience.
Yeah, you know, George, from an operating perspective, you know, I think it makes perfect sense. I think it's it's about transparency in that handoff. A lot of times today, you're right that we don't do that. We just send a final notice letter that says your account is going to be turned over to an agency, and that's all we tell them. We don't tell them a name. We don't give them a phone number. And I look at it sometimes. If you work in customer service, it's like a warm handoff, right? If somebody calls you and you need to transfer them to another team, another department, you can do, you can tell them, hey, I'll have, George call you, or somebody from George's department will give you a call, and that's all you tell them. Or I can make a warm call transfer and say, get George on the phone and say, hey, George, I've got Leslie on the phone. She needs help with this issue. This is, the situation
Always.
here, and hand it off, right? Great customer service. It's almost the same thing in this instance. You may not consider it customer service that you're going to a bad debt agency, but you're still providing that warm handoff that says, here's who your account's going to, here's their phone number. It's that transparency and handoff, I think. And so operationally, I think it's a positive thing. I think operationally, the only challenges might be to understand, organizations that might use multiple vendors in the bad debt space, and how, from a technology perspective, with their, statement vendors, their letter vendors, that they're able to acknowledge the right agency for the right patient. So I think, there's some technology in play there, or at least for organizations that might use multiple vendors in that space. But conceptually, I think I don't see any harm. Why that would be a bad thing for the consumer.
Mike, do you want to break in here?
Yeah, thank you, Leslie. I'm sorry, I just want to hit the pause button on our conversation briefly and just say a few words about TCN, the sponsor of today's webinar. TCN provides cost-effective call center solutions for traditional contact centers, collection agencies, and thousands of businesses worldwide. TCN continually has stayed current with TCPA and CFPB changes by introducing enhancements to its core platform, one of which is TCN's natural language compliance, which uses smart algorithms to build compliance rules naturally. Simply type your rule into the TCN Compliance Manager, and the natural language compliance engine will build an easy to understand compliance rule. One example of a rule would be deny outbound calls before 8 a.m. and after 9 p.m. You could even type a rule that would limit 7 calls in 7 days. There's no limit to the number of rules TCN's processing engine can compute. TCN software is a platform suite that also provides built-in data management services that eliminate data entry errors, business intelligence with reporting dashboards, call recording with storage, smart IVR with payment capabilities, speech analysis and transcription, and much more. Regardless of size, location, or application, TCN can provide robust solutions for your call center and collection agency. Give TCN a call or visit them at www.tcn.com for more information. Thanks again to TCN for sponsoring today's webinar. And Leslie, I'll hand it back off to you.
Okay, terrific. Thank you, Mike. Notice how Mike is handing his webinar off to me. I may not quite have achieved the Oprah fame of introducing royalty, but these guys are pretty close. So stick with us here. So let's talk quickly about Regulation F. Regulation F was a disappointment to some, but a breath of fresh air to others, and it remains to be seen whether the new leadership at the CFPB will allow it to be implemented November 30th, or may, as they did in the case of the qualified mortgage rule, take a pause or delay. But while that is happening, there's a number of features in the Regulation F that play out in a pretty important way in healthcare. And I promise before we wrap up, we're going to talk about passive debt collection, because in many instances of small balance collecting, reporting a trade line, even if you did not know where a customer was, to try to get the customer to initiate communication back was not an uncommon strategy. So we will get to that, I promise. But before we get to that, a quick question for Andrew, and then we'll pass this over to George for the flip side. Now that you know Regulation F would allow a debt collector, and now we're talking about charged off debt or past due debt or defaulted debt, allows a debt collector to use all these forms of modern technology, email, in messaging securely in some sort of social media platform, texting. would you envision, Andrew, that this would create an opportunity for a healthcare provider to outsource earlier in the revenue cycle, life cycle? And I'm not putting you on the spot about your health system, but just
Sure.
speaking, I know you're very active in HFMA and AHAM. Do you think this could prompt healthcare providers to want to outsource earlier?
I personally don't think so. I don't think it changes the timeline that providers would place. I think it's, again, the continuity of experience, I think is helpful. And so I think, as a provider, we would want our bad debt vendors, partners, to be able to communicate the way our patients want to, be communicated with within the regulations. But I don't foresee that it would change. I think, there's a perception from a customer experience about, being turned over to collections, being turned over to bad debt. So I believe most organizations would keep their timelines consistent. I don't think the change in medium would impact how early in the process accounts turned over to third party, in my opinion.
Okay. And so, George, do you think from an agency perspective that now that there are these other digital forms of communication, it would prompt an agency to want to change where in the life cycle it enters the picture?
From my perspective, we always want to move ourselves up as early as we can in the revenue cycle process. Still axiom of the earlier an account comes to us, the better our chances of recovery. I think part of what you face today, and I'll take Andrew's side for just a second in this, the pressures they're under in terms of reimbursement and trying to squeeze every dollar they can out of an account causes them to maybe to have kind of a counter cultural thought on that. Maybe they're going to start hanging on to that account a little longer because, back to our initial part of our conversation, volumes are down. And it's more important than ever for them to get every dollar of reimbursement they can out of what the existing inventory is. So I think it's going to be a while before we get to the next normal in terms of how revenue cycle ages out accounts, how long they leave it with their revenue cycle management partner or their early out partner. Because again, there's just more pressure on them for cash flow out of every account they have. So I think it's going to be a while before we see that next normal in terms of getting back to the way we're accustomed to accounts aging out.
So Andrew reported that the emergency room visits are down, but aren't the telehealth visits up by about 150%?
Telehealth is absolutely up, but telehealth is not a well-reimbursed service. And so, volume is only as good as the type of volume. I think most providers will understand. I mean, when you look at the pandemic, we may have many of our beds full. I mean, you turn on the nightly news and, one of the metrics is available ICU beds, right? And you hear across the country how very limited beds are in most markets. But that doesn't always translate to reimbursement or the bottom line. You've got much sicker patients where the reimbursement on medical patients is not always well. And so, historically in most organizations, elective surgical volume is generally reimbursed better as an industry. And so this change in COVID, it's not just about volumes shifting to more digital means. It's still about the type of volume and the acuity of the patients in terms of bottom line margin. So George is right. I mean, hospitals struggle. I mean, if you look on Becker's or Modern Healthcare, every week you'll see information about especially smaller community hospitals that are not part of a larger system closing and the struggle to stay afloat, especially in rural areas. You don't usually have as strong a payer mix. And so, being able to collect every dollar that's due, to George's point, is critical.
Now, speaking of the smaller payer mix, weren't you telling us the other day, Andrew, that there have been so many changes in price transparency and so forth that there's a new law coming that would require emergency visits to be treated as in-network, didn't you tell us, even if some of the participating providers aren't actually in that provider network. Will that help some of these rural hospitals?
Yeah, you're exactly right, Leslie. It's called the No Surprise Billing Act. It's part of the last legislation from the outgoing administration right before the new calendar year. And it goes into effect next January, so January the 1st, 2022. It's hard to keep up with all these twos here. And so there's several requirements in that new law, but one of the primary premises is just as you said, if you come to your nearest emergency room and it happens to be out of network for your policy, that your in-network benefits will still apply. And so from a consumer perspective, if it was me, I'm going to go to the nearest ER if I'm having a heart attack or an emergency.
Sure.
And my nearest ER may not be in network just because of where I live. And that's no fault of the consumer, right? And so I think it's a positive aspect from that, from a consumer aspect. And it puts an opportunity on the payers to pay an in-network rate and provides different mechanisms to how the provider and the payer will negotiate what that amount should be. And there's obviously state laws that could supersede some of that. So CMS is going to be releasing additional details, I believe, around July 1, around the implementation for next January on that. I don't foresee, though, a material change in reimbursement for most organizations. Yes, we have out-of-network claims for the ER today, but it's not. It's usually not a material issue that from driving reimbursement issues.
So let's go back to something you said a minute or two ago about people putting off some of their care for a variety of reasons that are beyond the scope of this. Do you think there's pent-up demand for elective procedures, or do you think that people might be privately getting sicker at home because they're afraid to go to the doctor or something if they would have? And if so, what do you think the impact of that might be on revenue cycle in, say, not 2021, but 2022?
$1 million question. So as George had his $1 million question earlier, I'd say that's a $1 million question for the providers. Is trying to understand, what that pent-up demand may be, or if there is pent-up demand.
Mm-hmm.
I think we all hypothesize with volumes being done, a lot of elective procedures being deferred, or even canceled in some cases if hospital bed availability wasn't there because of COVID. But what we haven't seen yet is that increase in those elective type cases. It's not that they're gone; they're not. Hospitals are absolutely performing, providing quality care, and it's not from lack of being able to provide it. Right? It's the lack of the referrals coming in, or the consumer having those procedures. And yes, we think there absolutely potentially is fear of coming to hospitals during the pandemic, of catching COVID. But I think we're going to see that start to subside, especially now as we're seeing great progress on vaccine distribution, and that continues to improve every day. That hopefully that will take away some of those fears. The real question, though, is whether that volume will come back, if there's a backlog that will make up for, or if we'll come back to pre-pandemic volume levels, or we'll stay at the volume levels we're seeing. And I think most organizations don't know the answer to that yet. There's not a great crystal ball to predict that. And we've seen such shifts in volume as the pandemic progresses, just like we went through that April-May time period last year, where a lot of things really slowed down, incredibly slowed down. And then the summer, things picked back up as we saw lulls in the COVID levels across the country. And then things slowed down again volume-wise when we saw the increases, in the November, December, January timeframe. And so I think it's still, time's going to have to tell. I don't have a magic crystal ball answer to that. I think we're all anxious to continue to see how that plays out. It's Leslie, I'd add that it's caused a real impact for a lot of organizations in budgeting. I mean, if you think of when you're running a large organization or even a small organization, how you plan to budget around that, not knowing what that volume is, because you cannot, it's hard to look back and just use your historical run rates in a year that it's nothing close to being normal.
Sure. Makes perfect sense. Yeah. But I'm seeing that we have a lot of brilliant data analysis people who are on this call. So maybe some of them have their magic algorithms and logarithms, and they're working on ways to try to do some of those predictive metrics or analysis
Right.
based on some data elements, and who knows how or why. I think that probably retailers are trying to figure out the same thing. I mean, people have gotten so comfortable ordering their groceries online, because who really likes to go to the grocery store? um, or any shopping. Why not just order stuff to come to your house, and then you can enjoy more time with your family, or running, or hanging out with your dogs, or whatever it is, your grandchildren, right, George? Um,
Yeah.
but I think that all of those are changes. Let's get to the tough topic, because people are clamoring to hear about this. As you know, Regulation F contains a prohibition against something that was called debt parking, or passive debt collection. And that is this: the practice of recording or furnishing a derogatory trade line on a consumer's credit file. Now, remember, let's put some of these things together. And I see we have some good friends from some of the consumer reporting agencies also on this call. Under the NCAP, the National Consumer Assistance Plan, it is not permissible to credit report a medical debt for 180 days from the date of service. And more importantly, if it appears that all or a portion of the ending of the debt is going to be paid by a third-party payer, private or government, then the trade line might have to be deleted, because it isn't technically the consumer's responsibility, right? So knowing those things, in the olden days, reporting a trade line, especially for smaller balance accounts, was considered to be a consumer-centric strategy, because you'd put the trade line out there, and one day the consumer would need to either get their free credit report every year or otherwise, and then would reach out to try to resolve the account. Now, proposed Regulation F, or Regulation F as published in the Federal Register, says that you have to give notice to the consumer about the debt being with the collection agency. Sorry, my dog Pete gets really upset about passive debt collection. Sorry, Pete. And so, basically the situation is that you would have to send the initial collection notice. You might not know where the consumer is. If the consumer was driving through town or on vacation and got care and treatment at a hospital or doctor's office in a place where they didn't live, and nobody knows where they are today, technically it might not be possible to give information about a debt to the patient. Andrew, is this something that you see as challenging, or will it change some front end process for you if you know that medical debts couldn't be credit reported until a debt collector ultimately gave notice about the debt to the consumer in the form of a collection notice or similar? And of course, remembering that nonprofit hospitals have to let people know if they're going to credit report, because it's an extraordinary collection action. Enough about me. How about you, Andrew? Is this something that will change your processes?
Yeah, it's a great question. My immediate answer is I don't see a major change in how we would operate today. I think the first thing we have to ask and answer is, do we want a credit report? I think if you look across healthcare providers, you're going to get different answers. I think there's been a history and trend of reporting medical debt to credit reporters, and I think it's probably time to step back and evaluate that. And we would look to our partners, folks like George and industry experts, to say, is the value there in credit reporting? And help me understand if the value is there financially. Does it truly prompt consumers to pay that otherwise weren't going to pay by that act alone? And I think I'd want to understand and look with our partners to better understand that before we would say, is this something that we think is valuable? Because the other side of that is the consumer experience. And again, I look at the consumer experience in totality, not just the collection experience. Is that consumer going to come back and receive services with me, in the future, and be upset over something like credit reporting? And so I think, there's been a lot more attention in the media around medical debt that just continues to grow, and some of the actions that providers in partnership with agencies take to collect the debt. And so I think the first thing I would suggest is, as an industry, we need to evaluate the value that reporting brings.
Perfect time, George, for you to chime in.
Those that know me well know that I'm not a big fan of credit bureau reporting, and that gets me crossways with some of my peers in the industry from time to time. Back in the early days of the CFPB looking at healthcare, there was even some conversation from the CFPB and with some of us to the CFPB of eliminating credit reporting for healthcare. I think CFPB kind of threw us a bone in terms of qualifying patients that we can report by giving them the opportunity, because in the past we couldn't use credit bureau reporting as a quote threat, and it was just an open door to be sued for UDAP. So I think that the CFPB at least has given us a bone in saying that we can notify the patient that we may credit bureau report, or at least give them notification that we're getting ready to. That way we get some communication back from the consumer. It's always been tough to quantify whether we get a good ROI on credit bureau reporting, simply because of the way consumers communicate with us. We tried several different ways of quantifying it and never really came up with a method that we thought was accurate. I guess in saying that, based upon what the CFPB has given us as an out, in terms of being able to tell the consumer, we're getting ready to report you to the credit bureau, I would think that would be of value to us to take a look at credit bureau reporting again and to use that as a tool to at least get the consumer to communicate with us.
Interesting. Well, I guess it would also require you to double check your mail handling processes to assure that you are processing the correct date on which the letter was really sent. A lot of mail houses have SLAs or performance objectives where they have 2 or 3 business days to process a letter file. So you'd need to be pretty accurate about the day the letter actually was posted.
Yeah.
And then you'd have to have some sort of controls to make sure if mail was undeliverable, you would know that in a timely manner, and that maybe you'd build in some cushions time-wise in your processes to make sure that you're not allowing accounts to, by default, get credit reported if the initial collection notice has come back unopened. So I can see this could be a road fraught with peril, and for sure would require a deeper dive in what your mail handling processes really are looking like. We have some other questions in the chat box about extracting a consent from a consumer and whether we think that healthcare providers are in a position to pass on those consents or make sure that those consents are transparent to the consumer so that the consumer will have the same process for how he or she is communicated with that accords with those initial preferences set. Andrew, do you feel comfortable that healthcare providers can pass on, first of all, get a knowing consent about the entire life cycle, and second, pass it on to their third-party vendors?
Yeah, and Leslie, I'd probably have to defer to attorneys to help answer that one, because I am not an attorney or legal expert. But I think George brought up the great example earlier when the TCPA rules changed and came out around that consent, and we did incorporate those consents into our general provider consent for patients and pass that along. So we have a precedent, if you will, of already doing that. Whether there's any changes, as we look to expand those types of consents in the digital space, we would look to our legal teams to help us, evaluate that.
Mm-hmm.
Leslie, if I can add to that, I think one of the dilemmas we face is there's so many different patient accounting system vendors. And within those different accounting or patient accounting system vendors, you have different versions of exports. Andrew's smiling because he and I have had this conversation many times. I don't feel we have the leverage with the patient accounting system entities to force change in terms of those exports. We've got to rely upon our healthcare partners to apply some leverage to the Cerners, to the Epics, to the Next Gens, to those kind of folks to say, look, you have got to update and bring your export features in line with what our revenue cycle partners need. And we're running out of time. If this takes effect November 30th of this year, you're going to get some pushback from those patient accounting systems in terms of applying resources to get us, whether it be consent or the financial information we need to itemize in that initial letter, our initial contact letter. So again, it's for me, it's one of those situations where we need to be in front of our healthcare provider partners and saying, we need your help. We need your help with all these patient accounting system vendors to update their exports. Right before I retired, I had a meeting with one of our large behavioral health clients. And the pushback I got from them, well, we don't think it's important today, and we don't have the people or the resources to do that for you because we were wanting to go ahead and get started on it. So that's kind of the pushback any of us from the ARM industry side would get if we went to those patient accounting systems. So long and short, we need the help of the provider organizations to go back to those patient accounting systems to be able to pass that kind of information to us.
Well, yeah, it's interesting. I'm looking out in the audience and I know I've heard Tim Hague talk before. He's in our audience today. Thank you, Tim. And I know that state collection has made entreaties to some of the patient accounting software companies and has gotten involved. And maybe that's something that more people in the industry should ask their clients about or should do, or call Tim. But I think that sometimes we take for granted that there is not a vendor interface and we just say, so be it. But other times, I think there are people in our industry that are super entrepreneurial and take advantage of building relationships with some of these vendors that can be helpful to our healthcare clients too, rather than just kind of sitting back and waiting to see things happen. And I suspect that this whole business of the digital front door and how it could be used by a health system's vendors, as well as by it to have a seamless transition of data, might be a really interesting conversation. So
yeah, Leslie, I totally agree. But I think George's point, I would just reiterate about, the agencies, the partners out there is reaching out and partnering with the providers. Because don't expect the provider to go knocking on the agency door to say how we're going to do this, because we're not the experts in the Regulation F or any of the other collection agency regulations. We're looking to our partners to assist us in that space, to guide us, provide us recommendations, and then together we'll approach the technology components and as well as timelines. Because George is right, there are challenges with the complexity of some of our systems, priorities, when we might be able to do that work. But if you have clients out there and you haven't reached out to them to start conversations in this topic, I would highly recommend that. Don't wait for the provider to come to you.
Terrific advice. All right, we have time for one more question before I have to give up my crown and return the podium to Mike. And Mike has done a masterful job this spring, or whatever season it is. Every day ends with Y, so I never know what day it is. Covering Arizona, New Mexico, and Maryland, 3 states that have continued to try to propose legislation to curtail credit reporting with respect to healthcare debts, and to also curtail potentially or charge an excise for bringing legal collections to collect medical debts. I believe also Maryland's Senator Chris Van Hollen has also proposed some legislation in the Senate to accomplish some of those things as well. What advice would you have, Andrew, for your peers now, other healthcare organizations, when you see some of these laws coming down the pike that are going to affect credit reporting or legal collections, or what property is subject to attachment if you ultimately get a judgment? What advice would you give to your peers, Andrew, about these types of laws?
Yeah, Leslie, great question. My first answer would be, if you have an advocacy component in your organization, is partnering with your advocacy team. Advocacy, if you have those roles in your organization, can be a great resource, to understand all the different pending legislation that's maybe out there, but also to help summarize and bring an operator's perspective to the legislatures. So I think a lot of times there's sometimes a lack of knowledge of how the operating process really works. And so I think partnering with your advocates, whether it's through your internal advocates, through American Hospital Association, local hospital associations, to help provide the impact operationally, because a lot of new rules, regulations have an administrative cost and burden that just continues to add cost and complication to the healthcare process at the same time. So I think trying to help folks understand operationally the impact would be my first advice.
Okay, George, how about you? What is your advice? I know you've had the opportunity to talk to the rule writing team over at the CFPB in the past about some of the nuances of healthcare collection. When you see these state laws coming down the pike being proposed, none have passed yet. What is your advice for peers in the industry?
Yeah, I go back to the meeting you and Andrew and I were in just a year ago, where we introduced the revenue cycle process to not only regulators, but consumer advocates, and you get the blank stare to a lot of it. And I thought Andrew did a great job of trying to explain it. I know ACA, through their advocacy efforts, are on the doorsteps of state legislatures as well as federal. So I think it's incumbent upon us as an industry and our industry leaders and our industry association continue to advocate for us as an industry and for healthcare vendors as well. We've got to come together with some synergy in doing this. So what HFMA did, along with the help of Tim Hague and state, in terms of the new publication HFMA, we just need more of that. So we need to bring not only the providers, but provider organizations to the table with us to help with advocacy at all levels, whether it be state or federal. And it's going to take more than just the 3 or 4 of us on this call. It's going to take a whole lot of folks to do that.
Well, thank you, Andrew and George, and thank you to a great audience for all your terrific questions. Mike, it's back to you.
Well, then allow me to thank you, Leslie, for doing a royal job of moderating today's webinar. I really appreciate you taking the time to ask some great questions and really sort of lead a great discussion. Thank you very much. Thank you, Andrew. Thank you, George. Thanks again to TCN for sponsoring today's webinar. Go to tcn.com to learn more. There was a link in the chat box, and it should pop up on your screen when this event is over, to share your feedback about the event and any ideas or panelists you'd like to see in a future accountsrecovery.net webinar. So please be sure to share your thoughts on that, because those are really helpful. Until then, everybody, stay well, stay safe. We'll talk to everybody soon, and take care.
Thanks, gang.